count. So it's important to know where you are in the lumbar spine because of lumbosacral transitional anatomy. So we'll count from cephalad to caudal, so from head to toe. And the easiest way of doing that typically is using your 12th rib. And you can see the structure here. And we'll go ahead and just assume that this is going to be our 12th rib here. Didn't really highlight that. So if that is T12, and sometimes you can have hypoplastic ribs or non-existent ribs at T12 or really big transverse processor, basically rib-bearing lumbar vertebrae too, but we'll kind of ignore that. So we're just going to say this is L1, L2, L3, L4, and we've placed our TUI needle down on the patient. And so now we know landmark-wise that our TUI needle should be around the L4 vertebrae level. So I'll move down further, caudal, so moving the C-arm towards the feet to continue with our count. And we'll just go ahead and assume then below this is going to be our L5 vertebrae. And so now we'll slide the C-arm lower down on the lumbar spine towards the direction of the feet. And now we know that this is L3, and we left our TUI needle on top of L4. So this is L4, and I'm drawing out these vertebral bodies. And you can notice in the lumbar spine, the vertebral bodies are sort of hourglass shaped. And then this, therefore, is L5. Yeah, kind of missed this, but L5 here. Next, we'll look at the interlaminar space. I'm outlining it right here. So fortunately, our patient doesn't have a lot of osteophytes or any sort of covering of this area such that we won't be able to get in. But if they did, sometimes a caudal or a cephalad tilt of the C-arm can help open up this space, okay? So next in the CPAP, we'll move on to position. So our position is going to be left perimedian L4, L5. So left perimedian L4, L5, epidural steroid injection right here. We've marked radiographically where we are in the AP image on the vertebral level using fluoro and with landmarks using the TUI needle. We'll now identify exactly where we want to enter into the interlaminar space. All right, we've made it to the placement section for epidural steroid injection. So this is the interlaminar space that we're going to proceed to place our needle in. This is our TUI needle. And so this is placement for our needle. So there's excellent universal terminology that the field of pain medicine is moving towards. There's a paper by Dr. Jatinder Gill that's published in Interventional Pain Medicine that I'll link in the description of this, but it's kind of outside the scope of this video. But suffice to say that we're not going to go too far lateral in the interlaminar space, and we're not going to go right in the middle because we want a more targeted therapy. So we're going to go sort of in between that area. All right, we're still in the placement section in CPAP for an epidural steroid injection. We've got our TUI needle here, and essentially it's in a coaxial view. And so what that means is it's in line with the x-rays. So if you were to, place a pencil like this and look at it from its side, it would look like this. But if you look straight down the eraser, it would just look like a dot. And that's what we've done for the TUI needle and the x-ray beams. Our position was L4, L5, left perimedian. And now, we decided on our placement, where exactly on that left side that we're going, and we decided it wouldn't be too far lateral and it wouldn't be right in the midline. And one thing I wanted to note is that sometimes when you're doing injections, you'll notice the pedicle right here and the pedicle right here and the spinous process right here. Don't get confused about how the spinous process is lower down than the pedicles. It still belongs to those pedicles, and you can see the lamina coming and making this V shape. And so this, belongs to L3 up here, and this belongs to L4. Our next step is obtaining a contralateral oblique view, so CLO for short. Our injection is going on the left side, and we have obliques 45 degrees to the right. We'll take an image here and see our L4, L5 interlaminar injection. Okay, we've made it to A, the approximation point of CPAP. So this is a contralateral oblique view, otherwise known as a CLO view, and it's used to assess the depth of a needle, whereas the AP view is used to more so understand the medial lateral or superior inferior positioning of our needle, or kind of like our X or and Y coordinates. The AP is also sometimes referred to as a trajectory view, and switching to a CLO view is not as simple as merely going to 45 degrees or obliquing the C-arm in the opposite direction of your needle or opposite side of your needle. since there's a lot of variability in individuals' anatomy. So a true CLO view is the angle by which a line parallel to the lamina intersects the middle sagittal plane of an individual. So even ideally on this image, these are the lamina. And then this would, and these could be crisped up, the lamina that I just drew over. But this line that I'm drawing here is the ventral interlaminar line, the VILL. And the ventral interlaminar line is basically the line and a theoretical line that approximates the margin, the ventral margin of the lamina. So our needle is pretty far advanced already, but this view is used for advancing the needle. So typically our needle would be further out here, and we'd be using this image to understand how far we need to advance our needle to get close to or approximate the ventral interlaminar line. So we'll advance just until we're nearby the ventral interlaminar line. Okay, so this is essentially the exact same photo, and I'll outline the lamina here like I had prior. And so obviously we're very close to the ventral interlaminar line. But the point of this photo is to remind you that you should be taking intermittent fluoroscopic photos as you're advancing to make sure that you haven't gone too far. And if you notice any change in resistance with your needle, you should make sure to take a fluoroscopic photo and or switch to the loss of resistance syringe, because anterior to this line is the epidural space, and you don't want to go further than that. So you'll look at your rads tech with a menacing glare and yell, "Shot," or "Picture," or "Fluoro." I was joking. You gotta be nice. You gotta request nicely. Photo, please. Great, we've made it to P, puncture. We have punctured the ligamentum flavum, and so our needle tip should be just ventral to that ventral interlaminar line, and our deposition of contrast should be this thick deposition just ventral to the ventral interlaminar line. Optimal contrast flow patterns are a video in and of themselves, so I will save that for now.